Thank you very much, Mr. Wimmer, for the excellent talk. May I now invite all the speakers to come on stage? I believe we still have 5-6 minutes of Q&A session. Yes, please. Well, while we're still waiting for our speakers to come up, I think we had a very fruitful 1.5 hours of sharing, not only in terms of the many excellent projects across the world, from Hong Kong to Australia to Vienna and so on. We also have very good examples of the ideas behind the concepts. I would also like to thank Professor Ian Forbes and Mary for reminding us of the sort of evidence that is behind the design and the effects of a heating environment, which is very necessary in confirming or refuting what we intuitively think would be beneficial to our patients. So without further ado, can I open the floor for discussion? If you would like to put up your hands for any questions to the speakers. Yes, please. Yeah.
It's Nicholas Lai, from an architect from Hong Kong. So maybe a question to Ian. So just now you make a criticism that architects, we don't change our mindset, even given the research findings. So, and this morning, earlier this morning, we heard from another presentation that they actually engage a full-time researcher in the Brisbane project. So a question to Ian, maybe. How will you see a collaboration process or between architect, medical planner, and maybe the researchers?
I think that's a bit of a misinterpretation. I basically, I think I said that first of all, that architects have a tendency to present things as case studies which don't have validity, because they haven't looked at things like the validity aspect. But they do change their minds. That's not a problem at all. And I think that the idea of having a researcher on board, somebody who does understand how to make that valid, is important. And I think that they've done just that. So it wasn't quite the same thing. I don't think it was, anyway.
Yes, another question there.
Can I just follow on from that? Roderick Lawrence, University of Geneva. We've had some very interesting presentations today and in the previous days. And I would like to come back to some of the points that have been raised by presenters on the floor, but also some of the other ones that have preceded them. And I think we've had some really remarkable examples of beacons for change. People have actually showed that innovation is possible, and you can call them case studies, Ian, if you like. I would say they're beacons for change. But behind that is, how do we get there? And I think we've had some very interesting presentations this morning about the process of getting there. And we can go back over 100 years for some firms, as David suggested. But is it learning by doing? Or is it starting from scratch? And my question really is, coming on to the presentations in this session, is how do we accumulate the evidence? I think this is a fundamental question underlying much of what has been said in this room. And I'd just like to hear from the speakers on the floor, how do you arrive with these beacons for change that we've seen over these 3 days? I think the reason that I'm asking this, and it comes back to a question about the architectural profession itself, and I was first trained in that profession, is that we're not trained to go back and do systematic monitoring of what we build. And today, we've got people here from government, from industry, and from academia and professional practice. Whose responsibility is it today to develop this accumulated evidence so that we don't start from scratch? Thank you.
Well, can I make a comment as a non-architect, but a researcher? I would think that venues such as this, where you've got, if you like, a community of practice, where people are learning and sharing, is the way that knowledge has been transmitted. I mean, the study that I was talking about, the mental health studies, that's been going on for almost about 4 years now, has to be written up and completed at the end of this year. And during that time, the significant shifts and changes from where we started when we first reviewed the first mental health intensive care unit, or as you call them, psychiatric intensive care units in the UK and probably here, and the mistakes that were made and the lack of understanding of what was being dealt with and the new models of care and the attitude towards recovery of patients. In the 4 years it's taken to collect data, analyse data, theorise and come up with something, the profession has been moving from what was a unit that was decommissioned because it was so badly built and poorly planned and destroyed, but it was based on guidelines, to the Maria Bashir Centre for Mental Health and the other exhibits we've seen here. That's quite a dramatic shift in what was designed. So I think it would seem to be a very subtle, engaged learning and sharing that happens in venues such as this and in the profession. So it's the research works with the profession. It's not, you don't necessarily have to do it yourselves within your practice because you're not trained necessarily to do that.
I certainly can add to that too, where as practice we've been working with the University of Melbourne, with clinicians, with the School of Medicine, not the School of Architecture, to actually talk about how we can develop tools for measuring real outcomes in some of these sort of different building types. We're not there yet, but we're thinking about it and we're working with them. And there's been some good forums that have recently been held with the Brain Research Institute in Melbourne as well, which is specific to mental health. But I think taking the example of Marie Bashir, that project in particular, there's some fairly, out of the norm things that we've incorporated into that building. But we've been working on some other projects where, other mental health projects, whereby we've actively said, well, for instance, the example of the staff station design, we've said, okay, well, what are all of the different models that are out there in terms of staff station designs? On another couple of mental health projects that I'm currently working on, I presented that open staff station model from that project, and they've all flipped out and said, no way. But it's, so it's about presenting the options, responding to the model, and then listening and saying, well, what's the right one for the right client? But as you say, to quantify it in terms of patient outcomes and the likes, I think is something we need to get a lot better at.
Just quickly, because of the staff station that you mentioned, and that was a big issue, the idea of risk and safety, which I talked about very briefly, that came up in our study. And the staff station was a metaphor for the whole attitude towards what could be and could not be. So you would get conflict between those who were understood what was trying to be changed in the way mental illness was understood and how it would be cared for, and those who had from past experience of violence had a different attitude to what they were trying to do. And I think the Forensic Hospital in Sydney, Forensic Mental Health Hospital, they actually introduced such a thing. And it was very successful because suddenly it became an accessible point of interaction with staff, which is what the patients want to do, and not a place of reporting or trying to attract attention or where the staff dismiss patients or watch their CCTV cameras and whatnot. So it's really quite a significant metaphor for the big shift that's happened in the way these places are built.
I just want to react to the word monitoring. It depends very much on which level we are speaking. There is ongoing the smart city movement, and the smart city movement has one of the basic fields, permanent evaluation. So if we speak about the city level, that's already established. But looking at the patient level, that's the other end. We have to think how can we re-evaluate it. But in terms of the Viennese program, there is a constant re-evaluation of the whole program of relocation. So they are running evaluation programs.
I just wanted to say, I think architects and designers and people have a tremendous opportunity to do good research work. And I don't want to discourage people from doing that. I think what you're seeing in the literature is the start of a very, very good base. I mean, recently there's been an enormous amount of studies done, And building on those studies is what we have to do. And we have to, but what I was saying earlier was that it's very hard for architects who present something as evidence, and you reach the positivist people who are saying that it's not valid unless it's got a randomised control trial. And you don't get into that debate. You get into that debate and you're gone, because you're never going to be able to justify it. But we can produce a lot of good social science methodologies that will defend what we're doing. And I'm encouraging architects to take that on, because the only thing you can do in context-dependent work is things like social case studies.
Well, I believe everybody will agree that this is really a very important area, that a lot of work still needs to be done. Before the session began, I was reminded to strictly keep the time, so I'm afraid I have to keep the last one as the last question for this session. I believe we have benefited a lot from the wisdom of our speakers, and you want to pick their brains more, please do during lunchtime, which, however, will be cut short to 1 hour. So we have to come back at 1:30 instead of 2 o'clock. And may I invite everybody to thank our speakers the usual way.